Good morning, everyone. The Select Subcommittee on Federal Impacts on Minnesotans and Economic Stability will come to order. It is Thursday, January 15th at 10 a.m., 10:07 a.m. To start today's hearing, we will first take up the adoption of our past committee summaries put together by members of our nonpartisan council team. There are 3 pending our action dated October 15th, November 13th, and November 21st. I do want to say we have members Rasmussen, May-Quaid, Mann, Utke, and Dibble all joining us virtually. Members, these are at the top of your committee packets. Senator Rasmussen.
Thank you, Madam Chair. I was wondering, do members of the committee have an agenda for today's meeting? And Madam Chair, when was that agenda shared with committee members?
It was fully posted online on Monday. 3 days ago? Yes, there is an agenda.
So, Madam Chair, we've had a list of testifiers, and the agenda for today was posted 3 days ago because I can't find it on the website, and I don't have a list of who's going to be in front of the committee today.
The content of the agenda has been online since Monday.
Madam Chair, does that include a list of testifiers?
No, but that's to the discretion of the committee.
And Madam Chair, could you explain to committee members why a list of testifiers is not given to members of the minority party until they show up for committee? I serve on a lot of committees, and I've never seen that to be the case. You might have someone who's added or subtracted last minute with different changes, but to show up, and it sounds like from my colleagues that are there in person that there's a list of 12 testifiers today. To not have any advance notice of who's coming to testify is something I haven't seen in my time in the Senate.
Thank you, Senator Rasmussen. Certainly wish you would have reached out prior to this. We have had some of the testifiers, but have been waiting for confirmation for other testifiers, as there has been significant turmoil in our state, and we have been working to have members, testifiers who are able to attend and who are able to be here today.
And Madam Chair, this was a point I brought up at our last hearing, and you said that the reason we didn't have it is because we had a member of staff who was ill, which is understandable, but I guess, to me, this seems like this is just going to be the practice of the committee to not share in advance, which is customary, a list of who's going to be testifying in front of the committee. And I guess, Madam Chair, did you have a list of testifiers, or did members of the majority party have a list of testifiers before they showed up today?
The first time I'm seeing this full list of testifiers is right now. My staff has been working to confirm testifiers throughout the week. Several of them have changed, and no, the majority party received nothing more than what has been posted online.
Thank you, Madam Chair, and I'd appreciate for our future meetings to, even if something's going to be updated, to have an idea heading into the committee hearing who's going to be testifying so that we can best be prepared for the conversation ahead. But Madam Chair, I wanted to also speak to the adoption of these reports, because this is also very unusual for a committee. I don't think outside of this committee I've ever seen the adoption of reports that have on there that they're authored by nonpartisan staff. You might have nonpartisan staff help you put together a report and offer it as a committee chair or as a committee for adoption. Madam Chair, I was wondering if you could give me another example of where this has been used in other committees in the Minnesota Senate.
Thank you, Senator Rasmussen. I know you weren't able to attend most of our first hearings on this, but we discussed this at length. We are a different kind of committee here. We're not hearing bills. We are understanding information. We're gathering information. And as a resource for the rest of our Senate colleagues and committees to be able to use going forward through the session, that has always been The role of this committee, it has been from the beginning what I said this committee would do, and the way that we have chosen to do that, which has also been communicated from the beginning, was through nonpartisan reports of the information that was gathered, so that it did not have a Democrat or Republican lean to it, but instead was put together by our nonpartisan staff for every member of the Senate to be able to use going forward through this next session as we navigate how we are going to respond to the impacts on Minnesota from the Trump administration. We have adopted packets in the past exactly like this. Your Republican lead, Senator Nelson, has had several discussions with me about this and has had no complaints. This is important information for us to get out to our colleagues, and unfortunately, we just haven't had a quorum most of our committee member meetings in order to be able to adopt these in the past, which is why we are adopting them as a group today. Any final questions, Senator Rasmussen, before we move on to the content of the hearing?
Thank you, Madam Chair. Yes, I would just say that I believe that this is a practice that we shouldn't partake in this committee or in the legislature more broadly. If the chair wishes to offer a committee report, or if a member of the committee, or even the committee as a whole, wants to offer a committee report, I think that's appropriate. But to use nonpartisan staff to basically summarize a very partisan agenda that's been put forth in this committee, I think puts our nonpartisan staff in a challenging position. And I would ask, Madam Chair, if you wish to offer a committee report, a summation, you could have partisan and nonpartisan staff help you in that function, but that's typically what we see committees when they adopt recommendations, adopt reports. I've served on task forces, that have legislative members, and that's been the process where members are putting their name to a report, a recommendation. They're not using nonpartisan staff and attributing a report to them.
Yes, thank you, Senator Rasmussen. You are more than free to vote no to adopt these reports. We have worked with nonpartisan. There has been no complaint from nonpartisan leadership on the creation of these reports. And with that, we will move forward. Senator Kupek moves the nonpartisan summary reports dated October 15th, November 13th, and November 21st. All those in favor? Aye.
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 Opposed?
Aye.
No.
Aye.
The motion passes. Now to the agenda for today. Thank you, members of the committee and community members, for being here today. I know this is a difficult, chaotic, and scary time for all of us who live here and love this state. This committee was formed to observe and react to the federal government's actions and impacts on the state of Minnesota. What we are seeing right now is unprecedented, unwarranted, terrifying, and heartbreaking. Our communities and neighborhoods are the subject of an invasion by our own federal government. The members of this committee have learned that the assault on Minnesota is coming on multiple fronts. Donald Trump and his cabinet are attempting to withhold billions of dollars from Minnesota taxpayers, funding that keeps families in their homes, kids in daycare and school, puts food in the fridge, and pays doctors and nurses who treat kids with the flu. That is money that is owed to Minnesota taxpayers. We are now forced to sue the federal government for every single dollar to stabilize hospitals, schools, small businesses, and household budgets. We are winning those fights in court. It turns out that you can't close the social safety net because a viral video shared by Elon Musk. But the budget bill Republicans in Congress passed last summer is very real and an existential threat to healthcare across our state, especially in greater Minnesota. Simply put, the Trump Republican budget subtracts close to $1 trillion, that's trillion with a T, from the American healthcare system and puts $50 billion back into it. That's a 95% cut of a system that was already stressed and not serving people in need. The distance between a person and their nearest emergency room is literally a matter of life and death. Today, we will learn that those decisions will disproportionately affect people living in greater Minnesota, where hospitals, clinics, and care workers are already pushed beyond the breaking point. To start off, we will be hearing from our colleagues at the Minnesota Department of Health, Assistant Commissioner Backstrom, Chief Epidemiologist Moiby will be joining us over Zoom, and Assistant Commissioner Ashby, if you could join us at the testifiers table.
Well, Assistant Commissioner Ashby is coming to the table. I just thought I would introduce myself and say a few words of introduction.
Yes, please.
Good morning, everyone. Yeah, thank you, Madam Chair. My name is Carol Backstrom. I'm an Assistant Commissioner with the Minnesota Department of Health. I am happy to be here this morning. I actually live in Duluth, so I appreciate the opportunity to participate remotely. I'm here to introduce our team and to say just a few words about the Rural Hospital Transformation Program. This is just a fantastic opportunity for us to really try to take a look and invest some serious dollars into rural health. This award that Minnesota has received is a recognition of the serious and longstanding challenges that rural communities often face in accessing care in rural Minnesota, and that rural hospitals and other providers face in remaining financially viable and able to respond to the needs of their communities. These challenges are not easy to solve. They're related to the demographic changes in rural areas, transportation barriers, and our overall system of financing healthcare in the United States. The award, though, is also a recognition of the extensive stakeholder engagement work that the state did in the development of the application and the set of proposed activities that resulted from that input, which are responsive to local needs, priorities, and capacity. This is a really substantial amount of funding that is coming to Minnesota, and we are excited to move ahead in this. But it's also a responsibility that we take very seriously. We are committed to approaching it with a spirit of transparency and learning, built on a foundation of strong oversight and measurement of results. I want to just point out that a few of our subject matter experts at the Department of Health are unavailable today. I'm very fortunate to have Nitika Moiby and Assistant Commissioner Anna Ashby from the Minnesota Management and Budget Office to join us today. All of our folks have been very involved in the development of this application and working hard with our stakeholder partners. So I will turn it over to, I believe, Nitika first. Nitika is our rural health workforce expert at the Department of Health, and then I'll turn it over to, we'll turn it over to Assistant Commissioner Ashby. Let me just add that because of the fact that some of our subject matter experts are not available today, please know that if I'm not able to answer any questions, I'm happy to be able to get back to all of you. Thank you. Nitika, thanks.
Thank you so much, Assistant Commissioner. We appreciate you joining us. Glad you could Zoom in from Duluth. And Ms. Moiby, if you want to introduce yourself and present your testimony.
Yes, thank you, Assistant Commissioner Backstrom, Madam Chair, and members of the Senate Select Subcommittee. My name is Nitika Moiby, and I'm with the Office of Rural Health and Primary Care at the Health Department. As the Rural Health Office of the state, we are charged with developing and supporting policies and strategies to optimize access to health care for rural and underserved residents. In execution of this charge, since 2019, the office has been publishing this Rural Health Chart Book as a resource for our stakeholders to understand the rural health landscape in the state. And we release an update to this resource in celebration of the National Rural Health Day that is observed on the third Thursday of every November. Next slide, please. I hope to give you a very high-level overview of this chart book and lay out some themes on rural demographics, workforce, access to care, and the health status of our rural residents. These insights really helped inform the direction and the scope of the state's application and plan for rural health transformation. It will come as no surprise to you and others that the demographic makeup of our state is changing. Residents 65 years and older will more than double from 2024 to 2075. We also know that rural residents are more likely to get health care through public sources of health insurance. Next slide, please. On the workforce front, Minnesota, like other states, faces the workforce shortage and a maldistribution problem, with the majority of our providers working in urban areas. Next slide, please. Consequently, the state has approximately 557 health professional shortage areas and medically underserved facilities. In response to this need, the state's application included significant investments in developing workforce pathways to grow our rural workforce. We've included initiatives such as scrubs camps for our rural high schoolers, apprenticeship programs for allied health workers, and additional role-based clinical training for advanced practice providers, psychologists, and residency programs for physicians. Next slide, please. As you may be aware, our rural counties have seen closures of obstetric services and behavioral health services. To that end, the application proposes bridge payments to eligible low-volume birth hospitals and birthing centers, so facilities can engage in a planning process to really balance the service line availability with the local population needs. In rural areas, primary care providers often end up filling gaps in care and are often the only source of coverage and source of specialty care, especially when it comes to obstetrics and mental health services. To respond to that, the application proposes the development of ECHO capabilities to connect rural primary care providers with our mental health specialists through virtual case-based learning. Funds were also proposed for fellowships in OB for our rural family medicine docs and simulation-based training for OB docs that are working in low-volume birth hospitals. Also included in the application is the development for mental health urgent centers to respond to the behavioral health needs of our rural residents. Next slide, please. Data also tell us that our rural residents have lower telehealth usage. To increase access, the application proposed the development of community-based telehealth access points in schools, pharmacies, local public health departments to really increase access to behavioral health and preventive health screenings. Rural Minnesotans, like their urban counterparts, also have chronic conditions. There are investments in the application to increase screenings for cardiometabolic conditions and referrals to more upstream drivers of health to really lower the burden and the prevalence of chronic disease conditions in our state. I hope this super quick overview has been helpful on the rural health landscape to your subcommittee. Next slide, please. And with that, I conclude my remarks. Thank you, Madam Chair. I will now invite my colleague, Acting Assistant Commissioner Anna Ashby, to share more about the state's rural health transformation application.
Thank you very much. Welcome to the committee, Ms. Ashby. Please introduce yourself for the record and then present your testimony.
Thank you, Madam Chair and members. I'm Anna Ashby, the Acting Assistant Commissioner for the Health Subcabinet at MMB. We've worked with MDH throughout the application process, adding capacity, supporting intake of ideas, looping in other interested agencies, helping with outreach to external partners, and together ensuring that we had an approvable application in front of CMS. Next slide, please. Just a note, we'll center today's presentation on what we submitted to CMS. We just want to make clear that CMS has discretion to require changes to activities and metrics as we implement this program. Also, we do have to submit a revised budget based on the awarded amount, which is slightly less than the amount states were required to submit in the application. Before I dive into the history of the Rural Health Transformation Program, I want to say up front that while we are eager for the opportunity to invest in our rural health infrastructure using these funds, we have to acknowledge that the amount of funding Minnesota will receive cannot meet all of the significant healthcare needs in greater Minnesota. As you just saw in the data overview, many of our hospitals, community clinics, behavioral health, and tribal providers are already challenged to meet the needs of their communities. Some of those situations are expected to worsen over the next several years. We took this funding opportunity very seriously, and our plan is designed to bolster the systems and mechanisms that support the health and well-being of rural Minnesotans and move rural providers and communities toward a more sustainable future. As you know, the Rural Health Transformation Program was included in H.R. 1, which passed in July of last year. The congressional language established a $50 billion pot of funds to be used across 5 years, half of which will be distributed equally among all states with an approved application, half of which was to be distributed based on metrics related to rurality and at the discretion of CMS to score. The Notice of Funding Opportunity, or NOFO, was published on September 15th. States had just over 6 short weeks to complete a very complex application, which required the state to chart a vision for the future of healthcare in rural areas and propose how to show that funding gets there through measurement and evaluation. We were very pleased in December that Minnesota was awarded just over $193 million for federal fiscal year 26, which is significantly more than we were expecting based on some of the national projections of some organizations. This is a reflection of the strength of Minnesota's proposal and the stakeholder engagement work that went into building it. As outlined in the NOFO, we're expecting funding awards to be announced each year for the subsequent funding period, and based on the progress that states can demonstrate with the funds in each preceding funding period. Even given the incredibly short timeline to put together this application, we prioritized hearing from external partners about how this funding could be used. Before the NOFO was released, MDH launched a website that included a form for public comments. Through that, we received over 350 responses from individuals and organizations. We were also able to host about 50 conversations with providers, organizations, Minnesota's tribal health directors, and others to get feedback on Minnesota's priorities. We met with legislative leads soon after our HTP was announced and to brief them on the opportunity and again to talk through the application before it was submitted. The RHTP team partnered closely with organizations representing Minnesota's hospitals, federally qualified health centers, community mental health centers, and certified community behavioral health clinics. And our application is a direct result of the work we did together. We were also pleased to submit letters of support with our application from all 4 caucuses of the Minnesota legislature, Minnesota's Republican members of Congress, Senator Tina Smith, Essentia Health, Sanford Health, the Minnesota Medical Association, the Minnesota Office of Emergency Medical Services, the Association of Minnesota Counties, and all of the partner associations listed on this slide. So we'll start with Minnesota's proposed strategic initiatives. These were closely aligned with the ones that CMS outlined for the program and reflect the feedback that we got through all of that external engagement. Please note, we included technology as a component to all of them. We see technology as a crucial way to reach the goals that Minnesota set out, but not an end in and of itself. And I'll briefly walk through a few examples of activities under each initiative for your awareness. So as I go through the initiatives we proposed in the application, please note each slide points to where in the project narrative more detail is available. The project narrative is posted on MDH's RHTP website, which is linked at the end of this presentation. So first, preventive care and chronic disease management were 2 clear priorities of external partners, which we knew and was reiterated through that public comment and engagement process. Some of the activities in that initiative include chronic disease screening, education, referral, and follow-up, chronic disease self-management in clinic and community, physical activity, nutrition, and upstream drivers of health referrals, and post-acute chronic disease care programs and support. Workforce was another crucial priority for the rural communities that we worked with during the application process. And we have several initiatives here, or activities, under the initiative, including introducing more high school students to healthcare careers, expanding rural clinic rotations, developing a technical assistance center for excellence in rural clinical training, and piloting the healthy workplace strategy with a subset of rural health systems. As many of you know, rural communities have expressed a want to maintain access to as many health services as possible in their own communities. And to that end, we included several activities in Initiative 3, including implementing or expanding models that integrate frontline staffing into care settings, developing community developing community telehealth access points, and providing local care delivery with mobile units for physical or oral health. We also know that healthcare services need to address the whole person, especially in communities where the number and types of health services that are available may be limited. Initiative 4 includes, as you can see, several different activities. I'll highlight a few: supporting the building of a children's mental health initiative, developing a rural telehealth services center, building rural obstetric skills through high-fidelity simulation led by physician faculty, and implementing an ECHO network that encompasses maternal health from prenatal through delivery, including postpartum care. Our last initiative reflected that we heard strongly from rural providers about the challenges they face in financial viability. To that end, we included several activities under this initiative, investing in a secure statewide integrated rural health data network, cybersecurity as a necessary tool to secure safe and secure operations of advanced technologies, and investing in revenue cycle management tools. Next, I'll talk briefly about the planning that the state enterprise is undertaking to implement the RHTP funding that we will be awarded. So since receiving word in late December of our award for federal fiscal year 26, even before that, we've been planning for how to very quickly stand up a program to disseminate funds and be able to demonstrate progress to CMS in order to continue to receive funds in subsequent federal fiscal years. All of our funding is currently restricted, meaning that they cannot yet be spent. We're hoping funds will be released following a January 30th deadline for the submission of a revised budget to CMS. Funds do have some unallowable uses. Most importantly, it is clear that CMS does not want RHTP funds to offset Medicaid losses. There are restrictions that don't allow the state to use RHTP funds for the non-federal share of any federally matched programs. We also have to spend money quite quickly by the end of the fiscal year after the one in which the funds were allotted. CMS has been clear that they will redistribute any unused funds. There's also a restriction on the amount of funds that can be used for administrative expenses of 10%, which includes not only the state's administrative expenses, but also subrecipient administrative costs. There are also substantial requirements that Minnesota must meet to continue to receive funding. We need to show progress on implementing the initiatives outlined in the application, adhere closely to our implementation plan and timeline, and report on metrics that we had to outline within the application. This is an incredibly complex grant with extensive reporting and evaluation requirements. States will be held to them when CMS considers future years of funding. Diving briefly a little further into metrics, the NOFO required that all states outline not only the initiatives and activities that the state will undertake, but how they will measure progress on stated goals. We worked with Minnesota Management and Budget's results team and consulted with providers where possible to determine what metrics we'll use. And we were cognizant that in some cases we'd have to measure based on process, as outcome-based data may take a few years to catch up to interventions. As we've stated, CMS expects significant year-over-year progress. Some examples of the metrics we outlined in the application are on this slide. The vast majority of the funding that the state receives will go to grantees, as I'll outline a bit later in the presentation. The state will also need to provide a significant amount of guidance and technical assistance, so grantees too can measure baseline data and progress along the initiatives that RHTP will fund. In terms of the mechanics of funding, we were cognizant that in the first year, due to the timing award of announcements, we will have less time than in any other year to the available funding horizon to show progress before we're redetermined for funding in federal fiscal year 27. So to efficiently get funding to where it's needed most, we'll focus in year one on funding to hospitals, FQHCs, CCBHCs, CMHCs, and tribal nations, little alphabet soup for your morning. With some competitive grant funding available and some expansion of MDH's existing workforce initiatives. I'm happy to talk more about why we chose those specific providers, but can broadly say these were priorities that were outlined in the congressional language and reflect much of what our public engagement work showed about the priorities of Greater Minnesota. In subsequent years, we'll shift to a greater share of competitive grant funding. For all funding years, I just want to be clear, funds must be spent on allowable activities to meet strategic goals. The state will need to meet stringent data reporting and evaluation metrics to continue to receive funds. As with all grants issued by MDH, awardees must provide thorough reporting of activities, document how funds are spent, and show that they're only being used on allowable activities. As part of our application, we had to demonstrate MDH's strong internal processes to validate information subgrantees submit and have safeguards in place to identify issues, seek clarification to ensure accountability. We're very cognizant of the importance of meeting all federal requirements for this grant, and our implementation plans reflect that commitment. This next slide was one that we developed during the application process to show the year one share of funding. Please note that in this table, our funding award is very close to the $200 million per year scenario, which is in the third column. To get into the weeds slightly, we propose that 70% of available funding in year one go to rural hospitals. Every rural hospital in the state is eligible to receive funds. This reflects how the program was talked about and outlined in the congressional language in the summer, and is a big need in our state, as in many others. Hospitals with areas of high need and high financial vulnerability will also receive some extra funding on top of a base. We also felt it was critical to include FQHCs, who provide comprehensive primary care and support services, particularly to people who are or underinsured, and community mental health centers, many of whom are also certified community behavioral health centers due to the massive need for behavioral health and substance use disorder care in Greater Minnesota. As I mentioned, all of these provider types were included in the congressional language. Tribal partners also have a set aside for funding to acknowledge the important role they play in providing services to their members and the importance of maintaining services in tribal communities. Competitive grant funds, as I mentioned, will be made available. We'll expand some of the existing MDH workforce initiatives that align with funding priorities, mostly around workforce. So a small amount of funding will be reserved for technical assistance, for example, providing support to subgrantees to set a baseline of data and then help them track progress on initiatives throughout the funding period. We're reserving some funding for administrative needs. Please note, the state's proposal is well under the 10% threshold for administrative spending, but acknowledges that we'll be undertaking issuing over 100 contracts in year one and need to have a very close handle on where funds are going and how they're being spent. During the implementation of this program, we will continue our partner engagement. We've met with all of the external partners who are getting funding in year one. We've shared outlines of available activities and timelines so they're ready to hit the ground running when the grant opportunities open. We'll also be hosting some public-facing webinars and providing opportunities for technical assistance once applications are open. Lastly, here's some information on how to stay engaged in this process. We're working on a plan to share updates and stay in conversation with legislative leaders in this space, and want to ensure that the public knows about our website, email, and places to get regular updates on RHTP. We'll also be hosting regional conversations, and we'll of course share up-to-date information with existing bodies and seek input whenever we're able. With that, that concludes our presentation.
Thank you very much, Assistant Commissioner. I just have a couple of clarifying questions, I guess. I'll start here at the end. With those allocations, and as you said, you're meeting regularly with all the partners that will receive direct funding. What does that process look like? Do they have to apply to you, all those rural hospitals? Can you just walk us through what that looks like for folks to get that funding?
Yes, Madam Chair, I'd actually like to defer to my colleagues at MDH to talk a little bit about that grant-making process, if they would.
Ms. Moiby, or?
Yes, Madam Chair, I'm
Yes.
happy to help answer that question. Yes, our plan would be to release notice of grant opportunities as soon as we learn that our funds are unrestricted by CMS, and we're hoping that hospitals and other entities would be eligible to apply for those notice of grant opportunities, and we hope that we can get our contracts done so monies can be allocated and work can begin. So we will follow the process we've always followed when it comes to grant making for our grantees.
Great, thank you. On page 32, as you're talking about metrics, you know, you were talking about how you'll need to essentially judge metrics based on sort of like incoming rather than outcome-based, which I understand with the tight turnaround on reporting and stuff, you won't learn the outcomes in time to do that. Is there space in this conversation around these metrics that you're turning in about, you know, about things that might be affecting it that aren't necessarily, you know, in a part of what you can what you can affect with this. I imagine housing is a concern in many of these communities who are trying to recruit healthcare professionals. Is there like space for part of that in the conversation?
Defer to Ms. Moiby.
Yes.
Yes, Ms. Moiby.
Thank you, Madam Chair. Yes, as you acknowledged, this is a reporting heavy grant program, and we understand that the tight timeline, at least in the first progress report that's due to CMS, our outcomes and our reports will look quite different. They may be more progress measure heavy versus outcome measure heavy. As we were defining and building the initiatives, we did think about, to the extent that we could, about some of the other externalities and interdependencies. When we did budget for residency programs, there was a small amount of money that we did allocate for short-term housing. For residents, we know that is a big bottleneck to grow residents and rotations of medical students. So we did do some rethinking on that, and I'm sure more and other barriers will come up as grantees are implementing it. We on our end are committed to providing subject matter expertise from our end and really working with the grantees to help them implement this to the best of their abilities given the confines of what CMS is holding us accountable for. We also hope we will have additional technical assistance vendors under contract to provide more technical assistance to our grantees in areas of cardiometabolic disease management, perhaps, or technology implementation to meet our implementation timelines.
Thank you. And with the admin costs that you have to be able to do both the grant sort of administration, getting it out to all of the subgrantees, that 1% I think that you allocated, is that also the admin, the only investment from this money that will be used to do all of the reporting as well? Ms.
Madam
Moiby?
Chair, thank you. Thank you for that question. Yes, we are definitely realizing that we will likely need to augment some of the support that's going to be needed from the state's end to understand and track our evaluation and metrics progress. We have also received new guidance as of yesterday in our call with CMS that there may be more flexibility in the definition of administrative costs, and we are expecting that organizations at subgrantees may be able to use some of the grant funds to support the implementation of the initiatives that they may choose to participate in. So we're hoping to meet with CMS again next week to get more clarity on specific parameters around budgeting and rebudgeting and allocation of funds for reporting and administrative costs, and we'll include all of that information for the outgoing grants guidance as well.
Thank you. And one final question, and then Senator Rasmussen, I do see your hand. I'll come to you next. In the first presentation that I think the Assistant Commissioner gave, one of the things that caught my eye was the increase in preterm births that have been associated with the loss of hospital birth services in rural communities. Can you talk a little bit about how widespread that is, what that sort of increase looks like? And I assume that's because we're losing not just delivery services, but also prenatal services that are, helping to keep babies and mothers as healthy as possible.
Yes, Madam Chair. If it's okay, I'd like to get back to you about that. So I have some data that I can share back with you from our colleagues who collect this data more closely than I'm familiar with. But I think your hunch is right in terms of the evaporation of those kinds of services does really impact the availability of prenatal care that mothers to be can get close to them.
Thank you very much. Senator Rasmussen, a question?
Yes, thank you, Madam Chair. I don't know who at MDH is best positioned to answer this, but was wondering for these progress reports that MDH will be sending to CMS, are those reports that will be made public or shared with legislators, or if legislators or members of the public are interested in knowing what those reports have, what's going to be the avenue for us to learn that information?
Ms. Ashby?
Sure, Madam Chair, we are happy to have a conversation about what we might be able to make available. We're expecting at least kind of monthly meetings with CMS to go over metrics and evaluation, and happy to have a conversation about that.
Thank you. Members, other questions? Senator Rasmussen, do you have a
Just-
follow-up?
Yeah, one other additional question I had. Madam Chair, this is for Minnesota Department of Health as well. Are there going to be any legislative proposals coming from MDH that could perhaps enhance Minnesota's future applications, as we're going to be asking for dollars through this program in the future? Are there policy changes that MDH thinks that the legislature should make that would make our application more competitive?
Ms. Ashby?
Madam Chair, Senator Rasmussen, I think what you're alluding to is some potential state policy actions that were outlined in the notice of funding opportunity. When we submitted the application, we had to kind of give a sort of status check to CMS about where Minnesota was for a number of those policy actions. Minnesota has a significant amount of those policy actions in place, and so I will just say we do not plan to directly seek legislative action. Would be glad to have conversations about how to continue to bolster our work in this area.
Senator Rasmussen, any follow-up?
Thank you, Madam Chair, and I appreciate the response, and would just tell the agency that if they would like to look at any of those as legislative initiatives, I'm happy to have that conversation, and we'll take a look at that status update in their report. So thank you, Madam Chair.
Members, any other questions? Thank you so much to all of you. I know some of you are pinch hitting today for folks who are out of the state, but very grateful for all of your participation and also for access to the full health book and all of the things you all are putting together. There are tremendous resources out there for people to understand the scope of the problem in Greater Minnesota. So thank you so much for sharing that with us.
Thank you very much, Madam Chair.
Thank you.
Thank you all.
Members, next we will have Caitlin Carroll, a professor at the University of Minnesota School of Public Health, come up to join us to discuss her research in this area. Welcome to the committee, Ms. Carroll. Please get yourself situated, and when you're ready, go ahead and introduce yourself for the record and present your testimony.
Is that working? I'm so sorry, I'm not sure. Try another port. Something else back here. Okay. Okay, all set?
Thank you
Okay.
very much. Welcome to the committee, Ms. Carroll. If you can please introduce yourself with your full name for the record and then present your testimony.
Yeah, thank you, Madam Chair, committee members. Thank you for having me here today. My name is Caitlin Carroll. I'm a health economist and an assistant professor in the Division of Health Policy and Management at the university. I'm also an affiliated faculty member at the university's Rural Health Research Center. My research focuses on rural healthcare markets with a particular focus on rural hospital closure, so I appreciate the opportunity to come speak on that topic today. I'll start my presentation with a broad overview of the causes and consequences of rural hospital closure, and then I'll speak in more detail about the effect of closure on affordability and hospital prices to reflect the request for testimony on that important topic. As committee members are likely well aware, hospital closure has been a challenge in rural communities for many years. Nationally, there's been about 150 rural hospital closures since 2010, and here in Minnesota, 4 rural hospitals closed during that same time period. When we think about declining access to care in rural areas, hospital closure is an important challenge, but it's certainly not the only one. Even at surviving hospitals, service lines are closing. An important example of this trend is in obstetrics. We've heard a little bit about this today, but here in Minnesota, 17 rural hospitals have closed their obstetric unit since 2010, either because the hospital closed entirely or because the hospital was able to stay open but closed down their obstetric unit. Rural hospitals close for a variety of reasons, but one important driver of closure is financial distress. About 40% of rural hospitals are unprofitable. That holds here in Minnesota and nationally. In terms of maintaining profitability, rural hospitals face two key challenges. The first challenge is low patient volume. Rural hospitals have faced large decreases in demand, especially for inpatient care in recent years. In part, that's because rural populations are declining, but in part, it's because rural residents have an increasing tendency to bypass their local hospitals and instead seek care at larger urban facilities. The second challenge for rural hospitals is that they tend to be more reliant on public payers like Medicare and Medicaid. They have fewer patients who have commercial insurance. That's important for profitability because commercial insurers pay more than Medicare and Medicaid for the same hospital services. So at rural hospitals that have limited patient volumes and relatively low reimbursement per patient, there can be considerable financial strain. That financial distress increases the risk of closure and also makes it difficult for surviving hospitals to maintain services and invest in quality improvements. When a rural hospital closes or a service line within a rural hospital closes, we always have to weigh the consequences of that closure against any potential benefits of regionalization. For example, quality improvements that can arise when people receive treatment at higher volume, more specialized facilities. With that said, research evidence is clear that when hospitals close, it can have serious consequences in rural communities. First, when hospitals close, it leads to treatment delays in rural areas and adverse health effects for patients with time-sensitive health conditions. Second, rural hospitals tend to be large employers in their communities. So when a rural hospital closes, it decreases employment, primarily in the healthcare sector, and can also prompt people to move out of rural communities, potentially in search of other work. Most discussion of the consequences of rural hospital closure have focused on these first two effects, which are certainly quite important. But there's another important effect of hospital closure, which is how it affects affordability of care, and in particular, how closure affects commercial prices being charged by nearby surviving hospitals. So I'll spend my remaining time presenting evidence on this third topic. Why should hospital closure affect commercial prices? First, when we're talking about commercial prices, we're referring to the prices paid to hospitals when they treat patients who have private health insurance that they get, for example, through their job. Unlike hospital reimbursement from public payers, for example, from Medicare, where prices are set administratively by CMS, commercial prices depend on market conditions, and in particular, they're set via negotiations between the hospitals and insurance companies that serve the same patients. So when one hospital closes, it may give nearby surviving hospitals increased leverage to negotiate higher prices because they now have fewer competitors that the insurer can contract with. Higher prices are important for patients because it can erode affordability of care. They're also quite important when we think about the broader functioning of the rural healthcare system, because if prices go up after a rural hospital closure, that means that closure can actually increase healthcare spending overall, even if healthcare use remains completely unchanged. So with those dynamics in mind, I'll present some findings from some of my recent work, looking at what happens to commercial hospital prices at these nearby surviving hospitals after a rural hospital closes. There's two key findings. The first is that after rural hospitals close, nearby surviving hospitals are able to raise their prices. Prices go up by about 4%, which is about $500 per admission on average. If you look at the figure on the right, you can see these price increases grew over time. So by 4 years after the closure, the price increase is closer to $1,000 per admission. When we dig into the data a little more, we find that this overall price increase is driven by surviving hospitals that had some sort of market power even before their competitor closed, meaning these surviving hospitals were either in systems or they were operating in markets that were already concentrated. The second key finding is that before these hospitals closed, they were actually charging lower prices relative to nearby surviving hospitals. So if you look at prices at closed hospitals versus, say, the 3 nearest hospitals, there's a $900 difference per admission. If you go out a little further to the 4th and 5th closest hospital, prices are almost $2,500 higher on average. These price differentials are important because it means that closure can sort of reallocate patients to more expensive hospitals and remove a low price option from the market. So even in cases where surviving hospitals don't raise their prices, closure is still having an impact on affordability, so it's effectively relocating patients to these more expensive facilities. So I'll conclude with a couple broad implications of these findings. First, that hospital closure has implications outside of declining access to care. In particular, hospital closure can impact affordability through these two sort of mechanisms, increases in prices. Any concerns about affordability do need to be weighed against potential benefits of increased prices at surviving hospitals. If you think about which hospitals are going to be nearby to a closed rural hospital, they tend to be also rural and also quite unprofitable. So it's quite possible that these higher prices are beneficial for them in the sense that they can maintain services or improve quality. The second implication of this work is that hospital closure does not only impact people who are using the closed hospital, because if prices go up at surviving hospitals, everyone pays those higher prices, not just people who used to receive care at the closed hospital. For people with high deductibles or high coinsurance rates, that means that they'll pay more at the point of service when they receive care. But even people with more generous health insurance are affected by higher hospital prices. That's because when insurers face high provider prices, it becomes more expensive for them to build networks and build plans. And so they tend to increase the premiums that they charge for those plans. That's another mechanism where hospital closure can affect affordability for consumers, even if they weren't using the hospital. Okay, I'll say briefly, my remarks today represent my own views and not necessarily the views of the university or my funders. Thank you again for having me today. I'm happy to answer questions either now or as follow-up after the hearing.
Thank you so much, Professor. We do have some questions. Senator Rasmussen, I'll go to you first.
Thank you, Madam Chair, and thank you, Dr. Carroll. I found the presentation to be very interesting, and thanks for bringing some data into our conversation today. One question that I had is, what does the literature or your research have to say on the impact that certificate of need or moratorium laws can have on the competitiveness of the healthcare landscape? Minnesota, as you probably know, has a hospital moratorium in place, and one of the concerns that I have is with the consolidation of hospitals into larger health systems that are serving urban areas and rural areas, that we could see some potentially anti-competitive behavior that's driving up the cost of healthcare. But just wanted to get your take as a researcher. What have you found? What have you seen? What are you seeing in the literature in this space?
Dr. Carroll.
Yeah, Madam Chair, Senator Rasmussen, thank you for that question. So you're right. I agree that certificate of need laws can constrain competition in hospital markets in general by restricting entry. I would say the literature on con laws and rural areas is relatively thin, unfortunately. But my intuition is that, what certificate of need laws do is restrain entry. And there's just not a lot of entry in rural markets to begin with because, demand for care is declining. The existing providers are unprofitable, so there's not a huge incentive for providers to enter. The second part of your question was about consolidation into systems. And I will add that I've done some work on this and other folks have done work on this. There has been a tremendous consolidation of rural hospitals into systems, mainly larger national or regional systems. So a lot of what we're seeing is rural hospitals are being acquired into a system that previously had no activity in that geographic area. So it looks like systems are using acquisitions to expand their geographic footprint. That does have pricing implications as well.
Senator Rasmussen, did you have a follow-up?
Thank you, Madam Chair. I have an additional question, if that's okay.
Yes.
Thank you, Madam Chair, and thank you, Dr. Carroll. I guess one of the things that I'm trying to understand, Dr. Carroll, is we've seen over the last decade plus, right, a pretty substantial expansion of the population of Minnesotans or Americans that are on Medicaid. And I was wondering, what impact has that had on rural healthcare access on some of these services that we see closing? I was wondering what your research or what the literature has to say about that impact.
Dr. Carroll?
Yeah, Madam Chair, Senator Rasmussen, thank you for that question. The research is clear that when states expand Medicaid, it does help hospitals stay open. And more generally, when we think about research studying changes in the policy environment where rural hospitals get more financing, particularly public financing, for example, through Medicaid expansion or through gaining critical access status, that does help hospitals stay open and it reduces closure rates substantially.
Senator Rasmussen?
Thank you, Madam Chair. And just one quick follow-up for Dr. Carroll. What do you see as in terms of healthcare productivity? Has that been going up, going down, staying about flat? When we think about more funding, both commercial and public dollars going into healthcare systems, just trying to understand what's happening with productivity, and is that a part of the picture here?
Dr. Carroll?
Yeah, Madam Chair, Senator Rasmussen, another good question. So generally speaking, economists and academics agree that the U.S. healthcare system does not look very productive in the sense that we spend a lot of money on healthcare, but we have worse health outcomes if we compare ourselves to, say, other high-income countries. Part of that is pricing. Part of the issue with spending, if you think about the specific example of hospital closure, to bring it back to this presentation, when a hospital closes, it might improve productivity in the sense that production costs go down, like you eliminate fixed costs at the closed hospital, and you aggregate more patients into fewer facilities, and so you fill their empty beds, and so their average cost is going down. But then because these hospitals also have market power, there's no incentive to pass those cost savings through to consumers and through to the system. So we see this sort of insidious issue where something like hospital closure can lead to a reduction in costs in the system, but an increase in prices due to market power.
Senator Rasmussen?
Thank you. Very insightful. I appreciate it.
Thank you. Senator Kupek?
Thank you, Madam Chair. I'm just curious, you had mentioned that a lot of people in rural areas are bypassing their local hospital for, hospitals in larger areas. Has there been any research into or surveys of why people are deciding to bypass, what should be a more convenient location to get their health care?
Dr. Carroll?
Yes, Madam Chair, Senator Kupek, that's a great question. So from a research perspective, it turns out it's much easier to sort of document the extent of bypass than it is to understand the reasons for bypass. The rule of people's general intuition is that quality or perceived quality is higher at these more distant hospitals. And so people are traveling with the hope that they're going to receive higher quality care. If we think about bypass in the commercial market, which has sort of an especially large impact for rural hospitals because those patients bring the largest revenues, there's also network considerations. It's also possible that, the exact service that someone needs is not available anymore in that rural hospital, and so they're forced to go further. So those are, I would say, the top reasons people think are driving bypass.
Thank you very much, Dr. Carroll. I don't see any other questions, so thank you very much for your testimony. We appreciate you coming to share your research with us.
Thank you.
Next, we will hear from Joe Schindler and Michelle Benson of the Minnesota Hospital Association. Welcome to the committee, both of you. Once you are settled, if you would just please introduce yourself for the record before you present your testimony.
Good morning, Madam Chair and members. Thank you for convening this conversation on rural health care. I'm Michelle Benson with the Minnesota Hospital Association, speaking on behalf of 140 hospitals across Minnesota in communities of every size. The Minnesota Hospital Association vision: Minnesotans are healthy and have access to the right care, the right time, in the right place. Our members directly employ 129,000 people. We invest over $6.2 billion in communities across the state. We serve outpatient needs through 9.8 million visits. We provide care for 2.6 million individual patient days per year. We care for families with 62,000 childbirths, and we provide more than $1 billion in uncompensated care. We serve patients regardless of ability to pay or status. We are caregivers, we are partners with nursing homes, medical professionals, EMTs, and others who provide care when and where it is needed. We are trusted community partners, innovative care providers, and employers of choice in a community. Hospitals are facing historic financial headwinds. In addition to the long-term challenge of government payments being below cost, current policies have added significant financial challenges. The directed payment program that became law in Minnesota last year, thanks to many advocates and the leadership of Senator Mann, is likely to not be approved as H.R. 1 prohibits new directed payment programs. This prohibition will eliminate an anticipated $1 billion that would benefit Minnesota hospitals. The 340B program is a decades-old federal program that allows hospitals to purchase drugs at a discounted price. It is an important source of savings for hospitals. Challenges to the 340B program and a lack of enforcement of 340B current law may destabilize this decades-old, reliable cost-saving measure and cost Minnesota hospitals even more. MA redetermination and work requirements may cause people to drop coverage and will increase hospitals' uncompensated care costs. Increasing costs in the private insurance market will lead to more uninsured or underinsured Minnesotans, further increasing hospitals' uncompensated care costs. Hospitals in general are facing headwinds, but rural hospitals experience these challenges uniquely. We appreciate the committee's attention to rural health care today and wanted to highlight our rural health care fact sheet that is in your packets. Minnesota has 77 critical access hospitals, the 4th highest in the nation. Minnesota has the 10th best rural geographic access nationally. 1 in 4 adults in rural Minnesota is covered by Medicaid. 77% of hospitals with negative operating margins are in Minnesota's rural communities. 18 rural hospitals in Minnesota are currently at risk of closing. In Minnesota, over 10 years, the enacted H.R. 1 estimated impact will reduce funding of federal Medicaid spending in rural areas by $4.3 billion over those 10 years. Cut rural hospital funding statewide approximately $1.65 million over the 10 years H.R. 1 impacts. For Minnesota's safety net hospitals, Medicaid work requirements alone are projected to reduce revenues by 8.8%, increase uncompensated care by 24.5%, compounding the chronic underfunding of the Medicaid program. Given this dire testimony, I do want to express a bit of cautious optimism about the RHTP grants as I turn this testimony over to my colleague.
Thank you very much, Ms. Benson. It's nice to see you. Mr. Schindler, if you can present your testimony and introduce yourself and then present your testimony.
Good morning, Madam Chair and subcommittee members. My name is Joe Schindler. I'm the Vice President of Finance Policy with the Minnesota Hospital Association, where I've worked for over 39 years. On behalf of our member hospitals and health systems, I want to discuss some of the details of the Rural Health Transformation Program, or RHTP. First, I would say, as Michelle mentioned, we are cautiously optimistic that this program could provide some level of funding to modernize and transform some of our operations of our rural hospitals. And we were pleasantly surprised to hear that Minnesota is proposed to receive first-year funding of $193 million, given the fact that they had applied for $200 million. So that was all good news. The federal RHTP objectives are focused on building care management for chronic conditions, workforce development, supporting partnerships, and a heavy emphasis on technology-enabled improvements for such things as telehealth and revenue cycle improvement. I want to be clear, though, the funding is not allowed to support uncompensated care or service line shortfalls, which was talked about by the department earlier. Furthermore, this funding is equivalent to less than half of the charity care costs that we expect due to Medicaid program changes coming up here, and I'll talk about those in a minute. Now, I know the state has had a multi-agency stakeholder group, but the Minnesota Department of Health has taken a lead role on behalf of the state to administer the program, as you heard earlier. MDH has clearly stated that the majority share of the funding will be allocated to hospitals, as they are the healthcare safety nets for their communities, especially when Minnesotans lose their medical insurance coverage or wrestle with high deductible health insurance coverage that becomes unaffordable for many. At the same time, I want to emphasize hospitals across Minnesota are financially in a fragile situation. With the latest audited financial statement data, we are showing a median operating margin of 2.6%, but still, that means 30% of our hospitals are losing money. And most of those are coming from rural areas. In fact, we know of 2 rural hospitals that have less than 10 days cash on hand, meaning they are very much in a scary situation where they may not be able to make payroll. Obviously, you are also aware of some of the painful service line cuts several hospitals have had to make over the last several years just to keep the doors open. In addition, hospitals and health systems in Minnesota are experiencing fairly steep increases to the provision of charity care and uncompensated care. MHA's latest community benefits data is showing a 40% increase in charity care costs in 2024 at $342 million as compared to $244 million in 2023. So that's, again, a 40% increase in 2024. When we talk to our members, that number is increasing ever still. Charity care is part of our nonprofit hospital's mission, and while these numbers are growing, our hospitals also contribute a significant number of other community benefits provided on an annual basis. In fact, the Office of the Legislative Auditor did a report last year that concluded hospitals' community benefit costs incurred exceeds their tax-exempt status. Now, I want to discuss the major challenge, one major challenge of H.R. 1, an estimate that was put out by DHS that 140,000 Minnesotans could lose their Medicaid coverage due to H.R. 1's new administrative barriers, such as 6-month redeterminations and the work requirements, and those kick in around 2027. MHA's conservative estimate for additional hospital charity care costs is about $270 million annually. Contrast that to the existing $342 million we have in the system as of 2024. In addition, a number of individuals and small businesses are currently either dropping coverage or enrolling in lower cost, higher deductible insurance plans due to the lack of congressional funding for the 2026 ACA enhanced premium tax supports, which are more immediately impacting hospitals. We expect uncompensated care costs related to those individuals to exceed $115 million starting right now. So circling back to the RHTP funding, while it appears to be a helpful program, it is targeted to benefit only 95 hospitals that have been identified as rural in Minnesota, which leaves another 30 or so urban-based community hospitals with no positive financial program from HR 1. And as you've seen in the media reports in the last year or so, several larger hospitals, especially in the Twin City market, are struggling financially. MHA has been working with the Department of Health to better understand the RHTP implementation plan. And we do have a few implementation concerns with the program as follows. We know CMS has asked the Department of Health to resubmit its implementation plan to match the funding allocation that was allocated, the $193 million. And then CMS has 30 days to review and approve that plan. So there's some delays that we're already seeing in the program. It also sounds like CMS will have to approve every little detail submitted by providers. So there's another time factor that's going to come into play. MDH has stated that they're implementing the program as a grant program, but that hospitals and other providers would get paid only after they have incurred costs related to the program, which puts not only hospitals but other providers in a pretty financially precarious situation. We are aware of no other state implementing the program in a similar manner. So again, we welcome the Rural Hospital Transformation Program funding to support rural hospital and healthcare access, but we have some concerns about the administrative costs along with the upfront spending expected from rural hospitals in order to participate in the program. So I'll pause there.
Ms. Benson?
Madam Chair and members, given the challenges that hospitals will face for the foreseeable future, we believe that in addition to RHTP, it would be prudent for the legislature to develop a funding pool to support and stabilize our hospitals. The fund should focus on hospitals' unique mandate to serve everyone regardless of ability to pay. In this time of historic underpayments, current cuts, and future uncertainty, actions to ensure the stability of hospitals can be a priority for Minnesotans in communities large and small across the state. We thank you for the opportunity to present to you and to the public the current state of Minnesota hospitals. Thank you, Madam Chair and committee members, for your commitment to the health of Minnesotans.
Thank you so much, both of you, for your testimony. One question that I have is, as you look at sort of HR 1 holistically and what it will mean for Minnesota for the healthcare industry, do you have an estimate at the losses that we will see here in Minnesota? Like, what will that cost us in lost Medicaid, Medicare? Mr. Schindler?
Yeah, Madam Chair, we have estimated that with the, and this is a conservative number from DHS, 140,000 Medicaid individuals could drop coverage for various reasons because of these redeterminations and work requirements. We estimate that would be a direct cost to hospitals of $270 million, which we expect to be charity care that is seen in both the emergency room. Some people will be admitted for inpatient care, and then some folks will be seen in clinics. So the combination of those three sites of care within hospitals and health systems, $270 million. And that's not to mention the $356 million in lost Medicaid revenue.
And that $270 million will be borne directly by the hospitals?
Across the state, yes.
It makes the $193 million that we're getting really not fit the moment that we're looking at. Members, Senator Rasmussen.
Thank you, Madam Chair. I have a question for our testifiers. You know, what are we supposed to tell Minnesotans when, they see new big $100 million plus hospital buildings getting constructed, when they open up the Star Tribune and read that the CEO of Fairview made about $4.9 million last year? What do we tell Minnesotans when we see these health systems shutting down rural access? We see their costs going up. We see facility fees for telehealth visits. We see surprise split billing when they show up. That's the frustration I hear from my constituents and people from across the state. And then they look and they see the CEO of Fairview getting $4.9 million as a nonprofit CEO, and they just are wondering why their costs are so high.
Mr. Schindler, Ms. Benson?
Madam Chair and committee members, certainly hospitals are large employers, so it's not surprising that they're going to have to replace plant and equipment on an occasional basis to meet the needs of their communities. These are, any building and construction really is to optimize care for individuals within Minnesota. I mean, this is directly in response to patient care needs. We don't just build buildings to have brand new buildings. We build them in response to the community health needs. In fact, we have federal requirements for community health needs assessments that identifies what some of those needs are, so.
Follow-up, Senator Rasmussen?
Thank you, Madam Chair. And we heard earlier from Dr. Carroll, who's a researcher who specializes in healthcare, talking about the impact on health systems becoming less competitive and driving up prices. And even when there are cost savings, even when there are productivity gains, that those are not being realized by patients. And so wanted, Madam Chair, to ask if the Minnesota Hospital Association would support looking at our hospital moratorium, looking at certificate of need laws, looking at other anti-competitive measures as we see hospitals continue to consolidate and jack up prices on Minnesotans, put facility fees and split billing, and pay the CEO of Fairview $4.9 million.
Ms. Benson?
Madam Chair, Senator Rasmussen, thank you for the question. Our hospitals do have to compete, but we're also required to take everyone who comes through our doors. There's no other business that faces that challenge. And as nonprofit entities, Minnesota hospitals have to be transparent about how they're spending the resources they do get. And so I would add a concern to your list beyond facility fees and split billing. What's the cost shift from private payers covering underfunding of the people who walk through our door? So I think there's a very broad conversation that can be had about hospital financing, but in the end, hospitals are required to provide care, and we should be paid for that care.
Senator Kupek.
Thank you, Madam Chair. I have two questions. Let me start with, I think, Mr. Schindler, you said we're doing it, this money that's this 1.93 that we are getting, that we're putting this out in grants and that other states are doing it differently. What are other states doing differently to distribute this? Because I do always worry with grants that sometimes it's not based completely on metrics. It's always based maybe on how good you have a grant writer. And I know in rural areas sometimes that's a problem we face, that we don't have a lot of great grant writers out there. So I'm just curious what other states are doing.
Mr. Schindler.
Yeah, Madam Chair and committee members. Yeah, and you did hear the word competitive grants from the department. Other states, from what we've heard, are allocating the money out based on size of hospital, just to get the money out. Now, I assume they're going to have some metrics about how the money is spent and get reports back, but that at least puts the financing on the side of the hospital or other providers to be able to make those purchases that they need of technology or whatever aims they are looking at that support the RHTP process. So that we feel like would be a better financing mechanism to enable purchasing these needed services.
Follow-up, Senator Kupek.
Not a follow-up, but a second question.
Yes.
But thank you for that answer. I appreciate that. And then the second thing is the other part that is very concerning to me, because I think one of our highlights last year, because we're hearing about rural hospitals, lack of money, and I was very proud last year that we just allocated some money with Senator Mann's bill to rural hospitals. And now to hear that that is not going to be allowable, is there some other mechanism then that we can use to take that same money and basically do what we'd like to have done last year and get that to the rural hospitals that could just use a little infusion to keep them afloat?
Thank you for that question. Senator Kupek, I have the same question. Can you help us understand why that won't be allowable and sort of what that means for those hospitals and that money?
Yeah, Madam Chair and committee members, I think, well, again, in a grant process, in most cases, you expect to get funding up front or at least partial funding up front, and then you have accountability on the back end for saying how you spent the money. And so I quite frankly, I don't know what the rationale was for how the program was designed here in Minnesota. Again, we feel like the problem we're seeing is that our rural hospitals don't have the cash flow available to go out and purchase technology-enabled wearables for people to do chronic care management or to build a new telehealth system. I mean, they're going to need some cash, upfront cash. Now, I will point to another program from a few years ago when we had, and we still do have, a lot of uncompensated care in the form of people delayed in hospitals waiting transfer to other care continuum sites. And the legislature allocated, I believe it was $18 million, a one-time infusion of cash, went to Department of Human Services. They came up with a very nice allocation methodology whereby they looked at the number of days by hospital that were submitted as days that were past, older, they've been in a hospital longer than 7 days awaiting transfer. And based on that, those metrics, they were able to get that cash out within a month, 1 month. So.
Senator Kupek?
I think just a follow-up comment. So, and obviously, what you're getting at here is like this new technology not available in rural areas. And I think this goes to what Dr. Carroll talked about, why people are bypassing then with a perception, and in this case, maybe even a reality of not being able to get that better care at that local hospital. And then we get into, it's the death spiral then. We don't have the money for this, they bypass it, and then it's a continuing downward trend. So thank you for your comments.
Thank you very much, both of you. I don't see any other questions from members, so we appreciate your testimony today. And also the information that you shared with us that is in the packets. The rural health fact sheet is really helpful. Thank you very much for attending today.
Thank you for having us.
Joining us next is Dale Kruger, CEO of the Minnesotans Hospital and Health Center. Monoman, sorry. I was moved to Wisconsin for a second. Welcome to the committee. Please introduce yourself for the record before you present your testimony.
Thank you, Madam Chairman and committee members. My name is Dale Kruger. I am from Minnesotans Health in Minnesota, Minnesota. We're a small rural hospital in Minnesota County. We are the first and only rural emergency hospital in the state of Minnesota. We're also a 32-bed long-term care facility. We have a 14-bed senior living center, and we also provide the ambulance service for our area. And we know that the rural health transformation was made to help improve access to health care, improve quality, improve outcomes, and allow for innovative changes that will help present and our future generations. But it does seem like the needs are different within every hospital, and that there's not a one-size-fits-all answer that will help us. For example, we're also limited by the IT systems that we have, that we are offered through, you know, our tertiary partners, affordability of all of the equipment. Equipment is very, very expensive, and cash flow is not always there to help us out with that. And then also, when you're looking at things, the cost benefit, you know, for example, we would love to have our own MRI service so that we can offer MRIs, you know, 24/7. However, we could never, by the time we buy the equipment, and we would never ever be able to have enough MRIs to pay for it. And so it's something where we have to buy that service from an outside partner that will come in and do MRIs for us, so we have our MRIs 1 day a week. And many of us rural facilities, you know, we basically really have to cut and paste all of our innovative ideas so that we can fit them into our community and help our community and our patients. And we always have to find innovations that will work for our community, help promote preventive care, disease management, you know, help retain workforce, which is always difficult in a small area or in the rural area, and keep being as efficient as we can. And so our story in Monoman is what I feel is a very positive example of how we really pivoted to make sure that we could offer and continue to offer healthcare services to our community, and you know, keep the care close to home for what makes sense, when it makes sense, and know when it is time to transfer that patient on to the larger facilities. And we have a long history of being a kind of a pioneer. Back in 1999, we were Minnesota's first critical access hospital. And in May of '24, we became Minnesota's first and only rural emergency hospital. And, you know, our mindset is that we have to find a model that's going to serve our community and do as much as we can with the funds that we have, with our expertise. We do serve more than 5,000 residents in Monoman County and White Earth Reservation. And nearly 52% of the patients that we have in our area, you know, identify as Native American. And among that population, there's higher rates of chronic diseases, transportation issues, resource limitations. And so making healthcare close to home is important, because the next closest hospital is 45 miles away, 30 minutes or more away, and many of these people would die on the way to the next hospital. And so having our hospital, you know, I want to say strategically located, but where it's at, we do stabilize and transfer as we can, and that does save many, many lives throughout the course of the year. And, you know, Monoman is the poorest county in Minnesota, and, you know, we found that, you know, the traditional inpatient model was not sustainable for our community because of innovations in healthcare and expectations by health insurance companies that there's less and less inpatient days. So we had a 10-bed hospital which had many open beds, yet we had to pay the annual fees just to have these open beds. And so making a change to become rural emergency hospital, we gave up our inpatient beds and the ability to do swing beds, which is care after the inpatient. But that's really kind of a terminology thing, because we can still keep patients as observation bed. And under rural emergency hospital rules, we can keep patients for an average of up to 24 hours per visit. It's not 24 hours per patient. It's an average of all your patients throughout the year. So we still keep patients. It's a terminology thing where, you know, they're admitted as outpatients, and so we get a different reimbursement rate and things like that. And we also take our patients back, instead of what was called swing bed patients under critical access hospital, we take them back as Medicare Part A patients in our nursing home, in our care center that's attached to us. And, you know, critical access hospital was formed about 25 years ago, and back in the 1990s, it was talked about that it was going to be a program that would probably last 20 years, 25 years, and new changes would have to come about. And over the course of the years, you know, it started off with critical access hospitals that you were reimbursed cost, not charges, but cost plus 1%. So that would always give you a little bit of cushion so that you could put, you know, some funds away for, you know, the new x-ray machine, the new lab equipment, things like that. But then the government changed, or the federal government changed it, and it's now cost plus 1% minus 2%. So actually, as a small hospital or as a critical access hospital, you lose 1% for every Medicare person that walks through the door. And you lose more than that on medical assistance patients that walk through the door. And so we engaged our auditors. We saw this program. We thought that it was something that was very good to investigate. We engaged our auditors, and it showed that it was the best plan for us, that we could strengthen our care delivery, stabilize our finances, and really position us for the future. And it has had an annual average, an annual impact of a positive $1.5 million a year. So that's a great benefit for us as an organization. Yet our volume has not decreased, because that one patient that was sitting as an inpatient doesn't really impact us all that much. But our ER, we serve about 3,500 patients a year in our ER. And that volume stays exactly the same. And so we do continue to treat the same number of patients. And we are a 24-bed emergency hospital. We have 5 ER bays that are many times full. We have 2 trauma bays. We still offer our observation bed services. We're a level 4 trauma center. We're stroke accredited. And we still provide all of the other outpatient services, the radiology, lab therapies. And people, as I've said before, the people that need longer term recovery do come back, you know, to us as Medicare Part A patients in our nursing homes. So we are able to continue to care for them. So after a hip replacement or knee replacement, if they can't be at home, they can come back and rehab in our facility. These changes, they've really created some staff satisfaction. We are minimally staffed. While we had a critical access hospital, we had 2 RNs and a nursing assistant that would take care of the inpatient and all of our ER patients. And sometimes that would get a little bit dicey, even though you end up with an average of 1. Usually it would end up that you have 5 in the inpatient, and then your ER is full, and there's just not enough bodies to take care of everybody. So we have staff satisfaction there. We organized ourselves so that we do not have the expense of traveler nurses that a lot of places have. And we're still able to supply all of the care close to home. So it really was a win-win for us and for our community, and most important for our patients. And what I would really like the lawmakers to know is that, REH is really working exactly as it was intended. It keeps essential services local, and it's taking into consider the realities of healthcare and how healthcare is emerging, you know, and all of the increased technology. And so the rural hospitals are not one size fits all. Innovation is critical, and in a small hospital, we have all of the exact same rules and regulations that a large hospital has to follow. We just have less people to take care of it. And so we still follow, you know, all the same Medicare rules and all of that, but it's just divided up over many less people. And, you know, a lot of times the insurance companies are pushing for outpatient services also as opposed to inpatient services. You know, you can go in for a hip replacement and you can go home the same day, you know, things like that. And so we continue just on focusing on our community and what makes us stronger, keeping our morale of our staff, and just always working for efficiency. And we want to make sure that we're there well into the future. I know that many of you know me because we've been here many, many times. And I've been on the Senate bonding tours, visited the capitals, had conversations with many of you in construction of a new hospital and nursing home for our facility. You know, our facility was built in the 1950s. Our hospital and our nursing home is set up that 4 residents in the nursing home share one bathroom that is a toilet. It doesn't have a sink, doesn't have a shower. It's the size of a small closet. If somebody comes in with, if somebody has a wheelchair walker, they cannot use the bathroom. And so we provide excellent care, and why I say that in our nursing home is that even though we're an old nursing home that is dilapidated and needs a lot of TLC, we're fully staffed. We have the best staff, and we have a waiting list for our nursing home. So even with I'm gonna say just a crappy building, we provide such good care that we have people waiting to come in. And we have an average occupancy of 94%, which is oftentimes, we can't admit somebody because of the male versus female thing, where we have 4 males for 1 bathroom, but we can't put a female right next to them because they share the bathrooms. And so just the inefficiencies of the building create a 94% occupancy, as opposed to where I believe we would be running at closer to 98% occupancy. And I do believe that we have a lot of bipartisan support for a new facility. We just can't quite get to that finish line, and we just hope that at some point our residents and our patients in rural Minnesota can see some of those advantages that a lot of the places in the larger cities see.
Thank you very much, Mr. Kruger. As you are thinking through the changes in HR 1 and the Rural Health Transformation Program, how are you planning for 2026 and 2027? And especially as you start thinking about those numbers that the Hospital Association shared with us, that 140,000 Minnesotans could lose their social services, their Medicaid, their Medicare. I assume in Monoman County that number is quite high for folks who are on those types of services. How are you prepared to, have that increase in uncompensated care?
Well, our uncompensated care is already very high because of our population. There's many of the population does not feel the need to even file medical assistance claims because they go, I'm not paying the bill anyway. And so our bad debt percentage is roughly between 9 and 10% compared to the state averages of 2%. So we already experience a lot of that. We don't have a good plan about how we're going to address more medical assistance, or I mean, less medical assistance, more charity care, except for the fact that, my job is to make lemonade. And, when we're given lemons, we're making lemonade, and we're always looking for ways that we can, reduce costs, create efficiencies, and still provide the great care.
Senator Kupak.
Thanks, and maybe more just a comment here, Madam Chair. First of all, Mr. Kruger, thank you for making the trip down from Monoman, and he is right. So I'm the author of their bill to get some money in the bonding bill, and even though this hospital is not in my district, there is nothing I think more worthy than given the population that his hospital serves in the state, and the fact that it is a community-based hospital. And yes, those bathrooms, that you're sharing just a toilet and that they're not ADA compliant, and yet still, there's the demand for those beds, and I can't think of another worthy place. So any of those other committee members on the bonding committee, please remember that when hopefully we have a bonding bill this year, which is super important. Thanks.
From your lips to God's ears, Senator Kupak. Thank you very much, Mr. Kruger. We really appreciate you coming out. You have an excellent salesman in Senator Kupak fighting for your hospital. But it really is helpful for us to see the challenges so that we can make sure that we are making our policy decisions, understanding the day-to-day realities of what you all are facing. So we really are grateful for you coming down here and sharing that with us.
Thank you very much.
Thank you. Members, next we have a number of testifiers joining us over Zoom to share their direct experiences. We will start with Dawn Bernfin. Please unmute yourself, and when you're ready, introduce yourself for the record and begin your testimony.
Good morning. My name is Dawn Bernfin. I am the president of AFSCME 65, Local 1119-1. And I am rural Minnesota. I work at Fairview Range Hospital. I work on the behavioral health unit, which is an acute psychiatric unit. And if you don't understand what that means, that is we get patients that are at their absolute, they're in the middle of a crisis. So we support them and get them to where they're able to be sent to, whether they're sent home, whether they are sent to CD treatments, whether they are sent to CBHH, to group homes, back to where they are able to function. And I'm going to try to temper my statements because I am very angry right now with all of this because everything that's going on affects me in so many ways. Not only with my employment, because we are the largest employer, second only to the mines in my area. But I have an adult son who receives Medicaid and receives services. I have this guy here who is attached to me right now. Yeah, thank you. And he was born premature, 12 weeks. So he has a lot of health issues going on and receives services that he has to go to Duluth and to several other places for to get PT, OT, pulmonology, neurology, all kinds of services for. The fact that this is going to affect not only I'm sorry.
Take your time. No rush at all.
Not only the way people access services. But economically, the people in my community, I'm very angry. You know, even myself, I don't have insurance right now. I cannot afford the insurance through my job for my youngest son, who is 18 and going to college to become a firefighter. It's over $700 a month just for insurance for us. That is more than my house payment. And so I was accessing insurance through the Affordable Care Act, and I do not have access to insurance anymore. So I am uninsured. A majority of the patients that come into my unit are uninsured or receive services through the Affordable Care Act or Medicaid. The patients that I serve are this wide spectrum. We get so many veterans, healthcare workers, law enforcement officials, from homeless people to just all the way across the board. And through no fault of their own, whether it's life circumstances, genetics, whatever, this is where they are. And we have a duty to treat them. And if they are afraid to come to the hospital because they're going to wind up with these astronomical bills, then they are going to suffer. Their families are going to suffer. And how can we help them? How can they go back to being these productive members of society if they are afraid to come in? And how can they come in if our hospital is no longer there? It makes no sense. And when we start closing, you know, parts of the hospital, whether it's OB, whether it is the behavioral health, whether it is, you know, whatever parts, and people start having to go farther and farther away, it's going to start clogging the system down the line. You know, people are going to have to start waiting longer for tests. People are going to have to start waiting longer for treatment. People are, you know, I'm sorry, he's biting my thumb. It is it's like a snake eating its tail. You know, it's so, I don't even have the words right now I'm trying to make you understand how it's just coming at people from all sides. There are so many people that I work with that receive Medicaid, that get help through the ACA, that, you know, that have, you know, I am thinking of a coworker that is going through cancer treatments, that, you know, many of them have chronic health conditions. And, you know, without that help, what are they going to do? You know, they're trying to work, you know, they're trying to do this, but they have to go farther and farther away. You know, so there's every speaker before me, there's something that I can relate to, that I could, you know, I could tell you a story about, I can attest to. So I just hope that there is something that, that can be done, that we can work towards, that we can hopefully get through to someone so that they can understand that this is not just, these are not just numbers. These are actual people. These are families. It's the whole community. Because, you know, it's like Jenga. When you start pulling one thing out, the whole thing falls down. Thank you.
Thank you very much, Ms. Bernfin. I do want to point out to members that in your packets, there's an article entitled Fighting to Protect Rural Northern Minnesota from the Effects of the Budget Bill. And in it, Ms. Bernfen has a quote that is really sticking with me. It says, "Our hospital is a lifeline. This isn't about politics, it's about survival. It's about whether our elders can afford their prescriptions and whether a parent can get their child to a doctor without driving for hours. Congress needs to come back and undo this mess. We won't stop fighting until they do." And Ms. Bernfen, I just want to thank you for the clarity and also draw members' attentions that this is all compounding on each other. All of these things that we've talked about throughout these months, SNAP benefits being cut or being more difficult for people to have access to, higher education, cuts in funding and research. At the same time that we are, making insurance harder for people to have, Trump has undone our work to make sure that medical debt doesn't count against your credit score, and now it will count against your credit score again. So just, I appreciate just your humanity in telling this story, Ms. Bernfen. Thank you very much for joining us today. I would like to turn to Chantel. Are you on? Yes, there you are. If you can go ahead and unmute yourself, introduce yourself for the record, and present your testimony. And I will say we are running a little bit short on time, so if folks can keep it concise, that would be great. Thank you.
Thank you, Madam Chair. So I'm Chantel Oxley, and I'm a home healthcare worker and a union member with SCIU 113, and I live in St. Cloud. So for me, this looks like me serving as my 13-year-old daughter's PCA through the Consumer-Directed Community Support Program under a developmental disability waiver. By choosing to provide my daughter with care this way, I can ensure compassionate and personalized care for my daughter within our home while also saving the state money in providing her services. I spend my time providing support for my daughter in activities of daily living and accessing the community safely to ensure that she grows to be a well-rounded individual who can participate in her community freely and in a way that maintains her dignity and safety. And while I receive payment for the care I provide, I don't have access to health insurance as part of my employment, leaving us to rely on Minnesota Care to provide health insurance for my husband and myself, because his health insurance at his job has been deemed unaffordable. So when she's been at school, I've been attending college at St. Cloud State University, and I graduated as a first-generation student with my bachelor's degree and a final GPA of 3.94 last month. This time last year, my post-graduation plan included taking my LSAT and attending law school, placing my family on a pathway toward upward financial mobility. As summer unfolded, the changes in federal policies were beginning to look as if this plan was going to be derailed due to the rising costs associated with tariffs. As I began my final semester, I began watching closely to see how the passage of the OBBB may impact my family. And by October, my husband lost his job as an infrastructure manager for a promotional products company, due in part to the rising costs associated with tariffs and their inability to continue to absorb those costs. Thankfully, the job market was kind to us, and he was reemployed within 2 weeks. In November, we were notified of our auto renewal for Minnesota Care that had been processed and that we continued to qualify for Minnesota Care into this year. Unfortunately, due to Congress's inability to extend the ACA subsidies that were passed during the pandemic, we lost our health insurance on January 1. When we looked at plans on MNsure, we found two things to be true. One, even the bronze plan would become our second most expensive bill. And two, we could not afford it while I was solely working as my daughter's PCA. So this means I can no longer attend law school. This has not only upended our family's long-term goals, but also our economic trajectory for years to come. So instead of applying for law school and anxiously awaiting my admission and aid packages, I'm here with you, telling my story of what could have been, hoping that the metaphorical rug that is my three daughters' health insurance and my oldest daughter's waiver aren't next, as this impact would be catastrophic for us. Thanks.
Thank you so much, Chantel. It's lovely to see you again. We met Chantel last week at the roundtable when we had this discussion up in St. Cloud. And I just want to say, Chantel, you've been on my mind this week as we've had these threats from the federal government to strip all of our resources from Minnesota, and how devastating that would be for your family. Your story already broke my heart. I think you'd be an incredible lawyer, and we should find a way to get you to law school. But I think understanding how deeply these impacts have already been felt by your family, and now having a threat of removing all of Minnesota's federal dollars around healthcare and SNAP and WIC, and it's just unconscionable. So I just thank you for coming and sharing your story again. You've been on my mind this week, and just really appreciate you sharing your story with us.
Yeah, thank you so much. It's been horrendous, and I did my part, right? I got the good grades, I went to school, I raised my kids, and watching it get pulled out from under me in real time has been horrifying. And so thank you for the empathy, Madam Chair, and the committee for doing this work, because our lives are being hurt right now. Thank you.
Thank you, Ms. Oxley. We will turn now to Jeff Miller. Mr. Miller, if you can unmute yourself and present your testimony, please.
Thank you, Madam Chair and members of the committee. My name is Jeff Miller. I'm 64, I'm retired, and I live in Albert Lea with my wife. I will be sharing with you my experience with healthcare, beginning with a letter I received from MNsure on September 24th of 2025. That letter informed me that I no longer qualified for the advanced premium tax credit that I had received in each of the 4 previous years of purchasing a qualified health plan through the MNsure exchange. For the year 2025, the credit that my wife and I received was $1,565. I learned that I could continue with with a similar Blue Cross Silver plan for 2026, but that would be paying approximately $3,000 a month for that family plan and approximately $1,600 for the single. My wife reached 65 last November, and this started Medicare. I kept the silver plan for the remaining 2 months of 2025. My single premium was $1,100 a month, which was a $100 savings from what we were paying for the family plan. Beginning in 2026, I elected to purchase a Blue Cross Bronze plan, which will cost me, or is costing me, $1,303 a month. This plan has an $8,500 individual deductible with a maximum out of pocket of $8,500 as well. The prescription coverage has a higher copay compared to my previous plan, as does the cost of an office visit. Our previous plan had a $4,000 deductible with an $8,700 max out-of-pocket single, $17,400 for family. Medicare premiums for my wife were $257 for Part B last year. They rose to $283 this year. We had planned to enroll in a UCare Advantage plan, which was really, I thought, a very good plan. It had some limitations, but we were prepared to enroll in that, and then suddenly that plan was discontinued. Because of where we live, there are very limited choices for Advantage plans that have high deductibles, out-of-pockets, and particularly if you're out of network. And so we elected to go with a supplement that currently costs $157 a month. Albert Lea is a city of 18,000, a little bit more, 18,300, something like that. Our hospital has been closed for many years now. Same-day surgery was recently eliminated. The physical therapy unit, Health Reach, was closed. Finding or seeing a specialist here locally is very rare, and if possible, it will be a long wait time in order to get an appointment. My 3 daughters were born here in Albert Lea. They're all teachers in this district, and I have 4 grandchildren, one of whom was born at the baby place in the hospital when it was functioning. The other 3 all had to drive to Austin to be born. It's about a 22-mile drive. In addition, we had an express care option here. It was housed in our local Hy-Vee. you could go to that express care clinic, and it was a $60 cost for the visit, plus any lab fee. I recently contracted COVID and wasn't sure if it was COVID or influenza. And I wasn't intending to go to Express Care. Of course, that's closed. And the local clinic has or started something that was a similar process where really you're seeing a nurse practitioner. That ended up being a $345 cost for the visit. I haven't gotten the bill for the lab fee yet. One of my granddaughters had a chronic ear infection and required basically same-day surgery to have some tubes installed. It was going to be nearly a 3-month wait to have it done in Austin. Can't be done in Alberta anymore. And finally, they just elected to have it done in Mason City at Mercy Hospital, and they were able to do that within the week. Quite a bit longer drive. My wife has some skin cancer lesions, precancerous lesions that needed to be removed. That couldn't be done here in Alberta. We had to go to Mankato to have that done. This is slightly related, I hope, and so I'm going to throw it out there anyway. I also recently received my 2026 proposed property tax statement. My property tax for a $284,000 home here in Albert Lea will increase from $30,730 a year to $4,434 a year. It's about a 20% increase. Due primarily to what our county is saying are increased costs and loss of revenue. Likewise, my property insurance is increasing from $1,800 a year to $2,200 a year. Needless to say, there will be some real pain to our monthly budget and subsequent spending decisions. The big, beautiful bill has been less than beautiful. Thank you for your time.
Thank you very much, Mr. Miller. And finally, we will go to Harmon Wiltz. If you could please unmute yourself, introduce yourself for the record, and present your testimony. And members, we are running over, so we'll only have a short time for final statements and questions. So please get those prepared if you have any questions for our Zoom presenters. Mr. Wiltz, please introduce yourself for the record and begin your testimony.
Thank you, Madam Chair and members of the committee. Really appreciate you holding this discussion. For the records, my name is Harmon Wiltz, and I farm with my family out in Swift County. It's about 2 hours straight west on Highway 12 of where you guys are sitting right now. It's been a great place to raise our family. We grow corn, soybeans, sugar beets, alfalfa. We have a small beef herd, and we're involved in the ethanol side of it too, ethanol business. My wife's a school teacher, and she has been for many years. We have 3 daughters, and they're all work in the agriculture industry and with their W-2 jobs, and are married. We have 5 grandkids. And however, if we look at the healthcare issue, it's really been a top concern for me because of really our goals of trying to get the farm transferred to the children and have them involved in the farm too. However, one of the biggest barriers that we've been facing is our daughters returning to the farm really is the cost of healthcare. And it really is a kind of a challenge to the point of we don't know if that's going to work or not. You know, the farm is doing okay, but because of tariffs and everything else, and our partners don't want to, buy our crops necessarily across the world, prices are low, and the farm economy is being really challenged right now. And so there's not a lot of extra money to be paying big insurance premiums to have them come back to the farm. So our goal would be that. And that isn't just our farm. Many farms out here are facing the exact same thing. They'd love to have their kids come back. The kids would love to come back. But when they're facing about a $30,000 a year insurance premium, it's a big deal. And a lot of times those premiums still come with pretty high cost. In 2022, just to give you an idea, in 2022, my insurance premium, and I have good health care coverage, was $13.13 a month. And now I just got the new bill and it's gonna be $21.69 for my wife and I. So the cost of healthcare is just really significant. And I had a chance to talk to a lot of people that were 65. I'm about 59 now, and they're like, hey, we finally got to live once we hit 65 and got on Medicare. We actually, all of our money didn't have to go for insurance, or a significant amount, I should say. So with that, I think that the cost thing is really, really a big issue. But as we go forward, my bigger concern now, or as big, I'm starting to see is the lack of places to go. We live out in Wilmer. Wilmer Hospital used to be a great hospital. It still is, but really it's gotten to be a point where some of the rural hospitals, Wilmer, Benson, different places, really you go in and they check you, and if you need something else, hey, then you got to go to St. Cloud. And St. Cloud's about an hour and a half for us. And for me, I can make the trip. My parents are in their upper 80s, and my mother needs to get shots once a month in her eyes, and traveling to St. Cloud is not a good option for them anymore. My father-in-law is in his 80s too, and the same challenges is, are we gonna have good care out here for them to deal with? Our local priest had an incident. He had some stomach problems about a month ago, went into the local Benson hospital, and they said, we really can't take care of you. We're gonna haul you in an ambulance to St. Cloud. And he said he didn't realize an ambulance didn't have very good springs, and it was a rough ride. But anyway, the point is, I think what's getting to be more and more of a concern for me is not only the healthcare cost, but do we have access when we really need it? We were blessed. Our daughter had a baby 3 months early and ended up flying down to Minneapolis to one of the hospitals. It was fantastic. She's a great little girl. But not having the access or not having that good insurance would have been a really big problem from that perspective. So these are the problems all of my neighbor farmers are really dealing with. Not only their own insurance, but how do we get our kids back into the farm operations as we go forward. So now I'm really giving you the picture, from a rural perspective, because I understand that cuts to the federal health care programs are really only going to strain the system more. And that's going to be tough on the communities like mine and everywhere else as we go. So thank you for listening to my testimony. Thank you for the work you're doing. And there's a huge need out here. People, we want to have dignity throughout their life and to the end too. So appreciate your time and keep up the great work on trying to figure this system out.
Thank you very much, Mr. Wiltz. We agree. All Minnesotans deserve the dignity of accessing health care when they need it, and really are grateful for you coming to tell your story. Members, any questions for our Zoom testifiers or any final comments? Senator Kupek.
Sure. Thank you, Madam Chair. Just a couple of, just kind of a wrap up here. First of all, thank you for everybody that testified today. I find today maybe one of the more illuminating hearings that we've had. And I know, last time we were together, there were a couple of questions about why are we holding these hearings, and I think today was a great example. Obviously, we're coming into a legislative session that is going to be shorter than other ones, and I think to get some of this information out there, particularly trying to figure out how, give us a little more run-up time. How can we get that money that we want to get out to our rural hospitals, It also opens up, I think, a door for just community members to be able to have a place to talk about the things that are going on and to get that. And also, we did not touch a lot on 340B, but boy, we need to work on that. That's one. I listened to that podcast, really. Can't listen to it at the end of my drive or it gets really sleepy, but that's a good one to listen to. We've got a lot of work to do on that. And I think, I think just we've heard a lot today, and I think there's a lot that we're going to need to do in what is going to be a really short legislative session ahead of election year. I know a lot of people say we're not going to get much done. We've got a lot we actually really have to get done to navigate and make sure that our healthcare system, particularly in our rural areas, stays propped up and going. So we can get through this and get people the healthcare they need, no matter where you live, whatever your zip code is. Healthcare, you have to have it. So thanks.
Thank you so much, Senator Kupek. Sitting next to you in HHS has been a really helpful primer on learning what is happening across the state of Minnesota in all aspects of healthcare. So grateful for your leadership in this area as well. Any other members have final questions? Okay, I want to thank everyone for joining us today in what are deeply troubling times. What we've learned these past few months and again today is hard to fathom. Access to healthcare is a human right, and Minnesota takes great pride in being one of the best states to live in because we have some of the best hospitals, researchers, and caretakers in the world. And we're learning today that those people are under siege by a federal government that is treating them as an afterthought. Every budget is a moral document. That's why in Minnesota we have, year after year, committed billions of dollars to hospitals, care workers, and support for affordable insurance. We know we don't act alone, and the Trump Republican budget passed last summer is an insult to our commitment to care for each other. We are supposed to be relieved that Minnesota's rural hospitals will benefit from $193 million from the federal government. But let's put that number in context. We will lose more than $2.4 billion per year, more than 10 times that amount in federal funding this year that will mean Minnesotans cannot access critical care. Care workers will leave their jobs or not join the workforce. Hospitals and clinics will close. Minnesotans will die because of these decisions. This is straight out of the authoritarian playbook, breaking and defunding infrastructure and then offering a small amount back and claiming to have saved it. However, the one big bill, which is not beautiful and is in fact tragic, did find topics that they felt deserved more funding. One of them was for Border Patrol and ICE agents, which will get an increase of $170 billion over the next decade. Let me restate that. We are supposed to be grateful for $193 million for critical healthcare across our entire state, while the federal budget will increase by about 1,000 times that to hire federal agents who are now invading our cities to violate our civil rights, imprison Americans without due process, and in the case of Renee Good, and again last night in Minneapolis, shooting us in broad daylight with impunity, with encouragement. If a federal budget is a moral document, I'm at a loss for words on what has happened to our morality and what we value as Americans. That is why next week we will turn our eyes to what is happening with federal agents invading our state, shredding our constitutional rights, taking our tax dollars that could be keeping people healthy and alive, and instead funding a police state that is putting us all in harm's way. Thank you for your thoughtful, insightful comments and information about what our hospitals, doctors, care workers, and patients are facing. I wish the people making decisions about American lives were listening to us today. Before we adjourn, please join me for a moment of silence in remembrance of Renee Nicole Good. Thank you. We are adjourned.